Ok, de nada, es un gran placer y un honor para mí de estar con ustedes. Y a mí me encantar Latinoamérica, así que estoy muy feliz de dar clase en Latinoamérica hacia Internet. Haré la presentación en inglés, pero
Gracias.
sí, pero si hay preguntas, trataré de responder en español.
En español, perfecto. Gracias.
Si no hago la mezcla de los dos idiomas. Entonces, so let's begin with this webinar. I tried not to do some Spanglish, and I'm currently working in intensive care unit, but I used to work in anesthesiology, and my first love is ultrasound, and so I have a link of interest with General Electrics. And I've worked a lot about point of care ultrasound in critical care unit, but also in the obstetric setting. So let's begin with what I would call the obstetrical paradox. As you know, point of care ultrasonography is the use of ultrasound by ourselves, clinicians which are not radiologists or cardiologists, and we use it as a stethoscope either for diagnosis or for ultrasound guidance. This is a very big step forward for medicine, and it is now adopted in almost all the specialties, and not only in anesthesia, critical care, and emergency medicine, but in all the specialties. In intensive care unit, we published this study showing that it is very, very, very useful and very used in clinical practice. One patient among 3 each day has a point of care ultrasound, and the diagnosis impact is very impressive of 84%, and the therapeutic impact is also very high. The two main kind of ultrasound performed are echocardiography and lung ultrasound in intensive care unit. And that's what we call thoracic ultrasound, the mix between echocardiography and lung ultrasound. When we look at emergency medicine, what's happened in obstetrics, because obstetrics until 2016 in obstetrics, point of care ultrasound was very, very underused when we talk about anesthesiologists. And you can see in this study in 5 very big maternities, university hospital maternities of level 3 in New York, Singapore, and London, transthoracic echocardiography, TTE, was underused less than 10%. So this is very strange, because in the obstetric setting, we have some very validated indications of point of care ultrasound. We can face acute breathlessness during pregnancy. We can face all the kinds of shock, cardiogenic shock due to cardiomyopathy, hemorrhagic shock due to postpartum hemorrhage, septic shock, anaphylactic shock, etc., etc. So we have some very good indications of point of care ultrasound in the obstetric setting. Of more, the pregnancy is the perfect condition to perform ultrasound, as everybody knows, because pregnancy is not a disease, and we need a non-invasive, non-ionizing monitoring. So this is the kingdom of ultrasound. So for us, it was a surprise to see that point of care ultrasound was very underused in the setting of obstetrics. So things are now changing, and we were sometimes the first, and now everybody is trying to publish in the field of point of care ultrasound in obstetrics. So we can use point of care ultrasound for a very wide range of indications. We can use cerebral ultrasound, transcranial Doppler, or optic nerve sheath diameter measurement. We can use ultrasound for the airway, for local regional anesthesia. We can use gastric ultrasound. And we also can use fast ultrasound for the diagnosis of postpartum hemorrhage and the differential diagnosis. and we can use what we call thoracic ultrasound, the mix between lung ultrasound and transthoracic echocardiography. So here is the plan of this webinar. We'll see how point-of-care ultrasound can help us in front of critical situations in obstetrics, acute breathlessness during pregnancy, shock states, fluid expansion, fluid management, prediction of maternal hypotension, post-spinal anesthesia, and cerebral disorders. So let's begin with the interest of point-of-care ultrasound for the diagnosis of acute breathlessness during pregnancy. As you know, acute breathlessness is something not very simple, which can be complicated with a lot of causes, and the etiological diagnosis is crucial. The etiologies of acute breathlessness we use out of pregnancy can be more or less available in the context of pregnancy. So let's recap a little bit with a lung ultrasound. When you see this slide, you can imagine that ultrasound will be very useful to diagnose all these causes, because all these causes are due to some components of the chest. So if we use cardiac and lung ultrasound, I mean thoracic ultrasound, we will probably be able to diagnose to make an early diagnosis, an early etiological diagnosis of acute breathlessness. So the first tool we will use is the lung ultrasound. With lung ultrasound, we will be able to diagnose 5 syndroma, 2 pleural syndroma, pneumothorax and pleural effusion, and 3 syndroma linked to the lung, the normal lung, the alveolar air and tissue, or air and water, which is completely aerated. It is pure gas, and so the ultrasound won't go through. You will see that later with a drawing, and you have some. You will see only some artifacts, horizontal artifacts, repetition artifacts called A-line. In the middle of the screen, you can see an interstitial syndroma. Interstitial syndroma is due to a thicker septa, either due to fibrosis or edema. And in this case, the ratio between the air and the tissue, or between the air of the water, is more in favor of the tissue or the water. And so you will have another kind of artifact, a vertical artifact this time, called B-line. And this time, again, you won't see really the lung, but you will see only some artifact, vertical artifact. At the right part of the screen, you can see what we would call a pelota pinchada. So there is no air in the lung. It is what we call atelectasis. And in the case of lung ultrasound, we call that a consolidation. This is the only situation in which you will see really the lung, and you will go inside the lung, and the ultrasound will go through the lung, because there is no air, there is only tissue, or so there is no air, a lake of aeration in this case. So what happened? We will see what happened, and we are going to see the semiology of lung ultrasound with drawings. It's sometimes easier. So in case of a normal lung, the ultrasound go through between the ribs, reach the pleura, and go through the 2 layers of the pleura, the parietal layer and the visceral layer. And then the ultrasound reach the alveoli, which are full of gas, and the alveoli reflect the ultrasound. So the ultrasounds have never gone through the alveoli, have never gone inside the lung, and you will only see a repetition artifact. Here is the pleural line, and you can see some horizontal A line, which are repetition artifacts of the pleural line. So this is a normal finding of lung ultrasound. We must focus on this sign in case of normal finding. This sign is called the lung sliding. It is due to the sliding of the parietal layer of the pleura on the visceral layer of the pleura. And this finding seems that the two layers of the pleura are in contact. It is crucial because in case of pneumothorax, you will have some air between the parietal layer of the pleura and the visceral layer. So the ultrasound will be stopped at the level of the parietal layer. And so you won't be able to investigate any lung sliding because the ultrasound are stopped above, and you won't be able to see any sign linked to the lung itself, to the parenchyma. Of non-ventilated lung, you will also have an abolition of a lung sliding. So it is not so easy sometimes to be certain that you have a pneumothorax. So the only pathognomonic sign of pneumothorax is the lung point. But firstly, we must see this sign, which is the lung pulse. The lung pulse is the transmission of the cardiac pulse to the lung, and you can see a sliding, not due to the ventilation, but due to the cardiac pulse. It can allow us to differentiate a pneumothorax, which have no lung sliding because the air is between the two layers of the pleura, from a selective orotracheal intubation, for example, an apnea, when you have no lung sliding, not because there is some air between the two layers, but just because the lung is not ventilated. So when the lung is not ventilated and the two layers are in contact, you will have a lung pulse. And when the lung is not ventilated because there is a pneumothorax, you will have a complete abolition of a lung sliding. So there is just one sign, because this sign of a lung pulse is sometimes lacking. So there is just one sign which is pathognomonic of pneumothorax. This is the lung point. In case of pneumothorax, you will have a detachment area. And if you can image this detachment area, you will be able to see one part of the pleura sliding and one part which is not sliding. This is a video clip with a VCAN, an ultraportative device. And you can see here is the lung point. Here is the detachment area. So in this case, you can be sure that there is a pneumothorax. Okay? Unfortunately, in case when you have a pleural effusion, you have two signs for the price of one. You have the effusion in black, and you have the consolidation, the pulmonary consolidation floating in this. It is very easy to see a pleural effusion, and lung ultrasound is a very interesting tool. It's almost a gold standard for pleural effusion. We can quantificate pleural effusion, we can make a diagnosis, and we can use ultrasound guidance, etc., etc. In case of interstitial syndrome, the things are almost the same than in case of normal lung, but this time the ultrasound can be trapped in the septa, and at this very particular point, at the septa, the ultrasounds are trapped and you have a reverberation artifact. And so at this time, at this point, the ultrasound device records a permanent signal, so it will put a white point and then another and then another and then millions of points one under the other, and all these million points will be responsible for what we call a comet tail artifact called B line. These B lines are crucial during pregnancy because we will see that pregnant women are very prompt to develop pulmonary edema, and so it is very, very, very useful to know this sign and to be able to detect these vertical comet tail artifacts, which are very pathognomonic of pulmonary edema. Here an example. The last sign that we need to see is the pulmonary consolidation. So this is the only case in which you will be able to properly image the lung, because there is no air in the lung. And in this case, you will be able to go through the lung and to see if there is something in the lung, for example, an abscess. And you will also be able to differentiate some atelectasis from consolidation due to an infection, and this can be very useful. In case of dynamic bronchogram, you will probably exclude an atelectasis. In case of atelectasis, you won't have this sign, which is called a dynamic bronchogram. So, using all these signs, Daniel Lichtenstein, the Pope of lung ultrasound, was able in 2004 to differentiate 3 profiles during acute breathlessness. It was out of pregnancy, but it is almost the same during pregnancy. And he told us that there are 3 anterior profiles with ultrasound. When you have a normal profile called the A profile, because you only have A lines, horizontal lines, the acute breathlessness will be probably due to a bronchial disorder, a pulmonary embolism, or a pneumothorax if there is an abolition of the lung sliding. In case of a B profile, what we call B lines, anterior symmetric bilateral B lines, we will suspect cardiogenic pulmonary edema. And in case of AB profile, a normal lung and an abnormal lung, we will probably diagnose pneumonia. So this is very, very useful, but it is not always accurate, because sometimes, especially in the context of pregnancy, you can have some pneumonia, bilateral interstitial pneumonia, the flu, for example, and it can mimic an hydrostatic pulmonary edema. And sometimes you can have some pulmonary embolism, which give you an infarction of the lung, and it can give you an AB profile. So the answer is to mix lung ultrasound and transthoracic echocardiography. That's what we call thoracic ultrasound. And if we assume that point of care ultrasound is the new stethoscope, okay, it is stupid to imagine that we will only listen the heart or only listen the lung. Nobody does that. So if ultrasound is the new stethoscope, we must see the heart and the lungs together, as we do usually with our stethoscopes. So Bataille and Stein-Silva show that very nicely in this study published in Chest, and they showed that out of pregnancy, the diagnosis accuracy of thoracic ultrasound was higher than the one of lung ultrasound alone for the diagnosis of hemodynamic pulmonary edema. Here is lung ultrasound diagnosis accuracy, here is thoracic ultrasound. Thoracic ultrasound is always superior to lung ultrasound. So in case of acute breathlessness, you must use lung ultrasound, and also you must mix lung ultrasound and cardiac ultrasound and use thoracic ultrasound to make a good diagnosis. It was also shown for the diagnosis of pulmonary embolism in these very interesting studies, the authors were able to avoid tomodensitometry in 58% of the cases, in 2% of the cases because they were sure that there was a pulmonary embolism because they found venous thrombus in the vena. And in 56% of the cases, they were sure that there was no pulmonary embolism responsible of clinical symptoms because they have no deep venous thrombosis, no right ventricle dilated, and another explanation, for example, B lines at the lung ultrasound. So in this case, you are sure that there is no pulmonary embolism, no severe pulmonary embolism. But it also means that in 42% of the cases, you still need a tomodensitometry. So all those studies are out of the context of pregnancy. In this slide, we can see that there is a kissing earth. The kissing earth can be due either to an hemorrhagic shock or a septic shock, a distributive shock. To make the difference between these two kinds of shock, hypovolemic and distributive, there is only one way in echocardiography, is to calculate the VTI. In case of distributive shock, there is a big vasoplasia, and so there is a big drop in afterload, and so it is the only case in which you will have an elevated VTI. So an elevated VTI is due to an anaphylactic shock or a septic shock. In case of an hemorrhagic shock, postpartum MOH, for example, you will have a low VTI because there is an absolute hypovolemia. But with visual echocardiography, it's not always easy to differentiate the two shocks. In both cases, you will have this kind of images, a complete collapse of the inferior vena cava. We can only interpret inferior vena cava in a spontaneous breathing patient in case of complete collapse. We cannot use it if it's not caricatural. If it's not completely collapsed, we cannot say anything about the interpretation of the inferior vena cava. In this case, what is your diagnosis? I think Juan Antonio has recognized an acute cor pulmonale, and so in this context, you must always interpret some images in the clinical context, and in the context of pregnancy and of a shock state. This is really in favor of a pulmonary embolism. So you will image your parturient in a subdifluid short axis view, and you can see in this view that the contraction of the left ventricle is not correct, and you have a D sign. And if you look at in a four-chamber view, you can see that the right ventricle is dilated. Okay, here is the D sign. So this is in favor of the acute cor pulmonale. So we really think that this patient has a pulmonary embolism. So we will do some venous Doppler. Here is the venous Doppler normal. There is no hyperechoic, nothing hyperechoic in the vena. And here you can see an hyperechoic sign. This is a thrombus, and it was a massive pulmonary embolism in the context of pregnancy. In this case, this is not very frequent in the context of pregnancy, but it can happen. You can see a pericardial effusion. So this is a tamponade because you have a swinging heart. The effusion is circumferential and very thick, more than 1 centimeter. There is a compression of the right ventricle, a compression of the left ventricle with a paradoxical motion of the septa. You have a very dilated inferior vena cava, and you have some respiratory variations of the Doppler values, for example, the E wave. When you have all these signs, you know that this is a cardiac tamponade, and this is very very critical. You can also investigate the ejection fraction of your parturient just with an able evaluation of the left ventricle, and it is very easy to differentiate a very good left ventricle from a bad ventricle or a very bad left ventricle. This is the case of cardiomyopathy, postpartum cardiomyopathy, and you can also see some Takotsubo in the context of pregnancy, notably after a postpartum hemorrhage. So, when your parturient is in shock state, or when she's in cardiac arrest, you will look the signs that we have just talked about. And after that, you need to monitor the cardiac output. And the only way to monitor it in a non-invasive way for the cardiac output is the echocardiography. And you can see the conclusion of this study saying that cardiac output measurement by transthoracic echocardiography is a gold standard during pregnancy. So the other non-invasive monitoring during pregnancy are not very well validated. So transthoracic echocardiography is a discontinuous monitoring, but it is very well validated in the context of pregnancy. So you will monitor the cardiac output in case of shock state with your transthoracic echocardiography. Once you have made the diagnosis of a shock state, you will need to manage your pregnant patient and the hemodynamic of your pregnant patient. And the hemodynamic management of a preeclamptic patient is very, very, very challenging. It is challenging because on one hand, you have an elevated risk of hypovolemia and of hypoperfusion of the organs and of the fetus. And on the other hand, you have a very, very elevated risk of pulmonary edema. This is completely specific to the pregnancy, and especially when you have a severe preeclampsia. When you have a severe preeclampsia, the woman with severe preeclampsia is a time bomb for pulmonary edema. It is like a perfect model of pulmonary edema because those patients have an increased afterload, an increased preload due to pregnancy, a reduced oncotic pressure, an elevated hydrostatic pressure in the pulmonary capillaries, and an elevated capillary permeability due to severe preeclampsia, and also a reduced lysotropy and an alteration of the diastolic function. So this is really an experimental model of pulmonary edema. So what does the guidelines say? They say that we probably have to use an ultrasound monitoring in case of severe preeclampsia for the hemodynamic management, but we don't know how. We are going to have some new guidelines about preeclampsia in a few months in France, and you can be sure that I will insist about the very important role of point-of-care ultrasound in this case. So how can we use point-of-care ultrasound in the setting of severe preeclampsia? What we need is a prediction of fluid responsiveness. Okay, but it's not so easy because parturients are generally spontaneously breathing, and they don't have invasive monitoring of the arterial pressure. They don't have any arterial catheter. So in this case, we are looking for a fluid responsiveness in this, which is validated in the context of spontaneous breathing patient without an arterial catheter. So the only, and this validated in this case, is the delta VTI after passive leg rising. But the question is, is it possible to make that in the context of pregnancy? Is it possible to recruit enough volume by making the passive leg rising, even when you have a compression of the inferior vena cava due to the gravid uterus? So we performed that study in 2013, and we show that the passive leg rising and the delta VTI after passive leg rising is completely valid in case of pregnancy and in case of severe preeclampsia. So we can use delta VTI even if the woman is pregnant and even if she has a compression of the inferior vena cava due to the gravid uterus. So this is very well validated with a very good area under the curve, and you can see that the delta inferior vena cava is very bad to predict fluid responsiveness. Patients were fluid responsiveness. So clinical signs, clinical examination is not enough to predict which parturient with severe preeclampsia will need some fluid bolus, some fluid expansion. So we need to monitor it with point of care ultrasound. Okay, this is a crucial information because a few years ago we really thought that all severe preeclampsia, when they were in oliguria, they needed a fluid expansion, and this is not the case. And the second conclusion of this paper was that delta VTI above 12% was really in favor of fluid responsiveness. So the ability of the delta VTI after passive leg rising to predict fluid responsiveness in pregnant women was recently confined in this study and several studies. So it is well validated that we can use delta VTI after passive leg rising to predict fluid responsiveness. However, to perform cardiac ultrasound in a preeclamptic patient is not so easy. Sometimes it's not possible to have some good images, and sometimes the people working in obstetrics, especially anesthesiologists, are not very familiar to echocardiography. So we investigate further, and we wanted to know if lung ultrasound could be of interest in the hemodynamic management of a preeclamptic parturient. So we performed another study in 2014 in a severe preeclamptic patients compared with a control group of normal pregnancy. And we firstly showed that the extravascular lung water was more elevated in the group of severe preeclampsia patients. So we used the echo-comet score, and the echo-comet score, which reflects the extravascular lung water, was really higher in the group of severe preeclamptic patients. The second finding of this study was to show that 4 parturients in the preeclamptic group exhibit a B profile, but only 1 in clinical signs. So we confirmed what Luna Gargani showed in an experimental model, which is that the B lines appears before the clinical signs and disappear before the resolution of the symptom. So the B lines in those preeclamptic parturients, in those preeclamptic patients, which previously had some normal lungs, there were a very good correlation between the filling pressure and the B lines. So the pulmonary edema during preeclampsia is probably due to a cardiogenic pulmonary edema, is probably due to elevated hydrostatic pressure. As you can see, with the number of B lines, we were able to predict the filling pressure. Finally, we also showed that when the preeclamptic parturients had a B profile, they were very unlikely to be fluid responsive. So when you have some B lines in the context of severe preeclampsia, you probably won't have some fluid responsiveness because the delta VTI was very low in the group of preeclamptic parturients. We were very happy to see that another team confirmed our findings. Lukovnik and her team showed that exactly the same thing, that the extravascular lung water is elevated in case of severe preeclampsia, and it was normalized at day 4, and that this pulmonary edema was linked to elevated filling pressure, so it is maybe a cardiogenic pulmonary edema. They also confirmed that these patients was unlikely to be fluid responsive in only 50% of the cases. So to summarize, we can really use, and we must use, thoracic ultrasound for the hemodynamic monitoring of a parturient patient, especially in case of severe preeclampsia. In severe preeclampsia, you must be very restrictive with the fluids, because as I told you, only half of the patient, even in case of severe preeclampsia with oliguria, the worst case, only half of the patient really need fluid. So we must be restrictive. In case of clinical signs of hypoperfusion, we must assess first fluid responsiveness with a delta VTI after a passive leg raising. In case of low delta VTI after passive leg raising, the fluid responsiveness is very unlikely, so don't give fluid to your patient. In case of high delta VTI, above 12%, your patient is probably fluid responsive. She probably needed to increase her cardiac output, but we don't know if it is safe. To know if it is safe, we will look at the lung and we will look at some B lines. If there are no B lines, you will know that your patient will increase her cardiac output and it is safe. So you must give fluid to your patient. If your patient has some anterior bilateral B lines, it is very complicated. Maybe you can discuss a mini fluid challenge, or maybe you can discuss with your obstetrician to know if a cesarean section, you must wait, you must know the benefit-risk ratio to know if you will pursue the pregnancy or not. Okay, so this algorithm is crucial. It is very, very difficult to manage a patient with a severe preeclampsia, and this is a very simple algorithm to know if your patient needs some fluid or not, and to know if you can give fluid very safely or not. Another application of point-of-care ultrasound in obstetric is the prediction of spinal hypotension after spinal anesthesia. So this is more for anesthesiologists, but it's very useful because, as you know, our prophylaxis strategies to prevent maternal hypotension are non-individualized. We do the same for everybody, and this is not good practice, I think. So we performed this study to see if there is a correlation between the delta VTI after passive leg raising before the spinal anesthesia and the occurrence of the spinal hypotension after the spinal anesthesia. And we saw that there is a good correlation, and we saw that we can predict with an area under the curve at 80%, we can predict the occurrence of spinal hypotension after spinal anesthesia. In brief, when your delta VTI before spinal anesthesia is below 8, your patient is very unlikely to exhibit spinal hypotension. In case of severe hypovolemia with a delta VTI above 21 before the spinal anesthesia, there is hypovolemia, so your patient will have a very big risk to have a spinal hypotension. So maybe you need to give fluid to this patient. And between these two values of 8 and 21, this is the gray zone concerning only 30% of the patients. And for those patients, we don't know exactly what to do. But you know, this is very interesting for me to know that if we know the hemodynamic status of our parturient before the spinal anesthesia, we will be able to better manage her. Finally, we can discuss briefly cerebral ultrasound, because in the context of severe preeclampsia, you know that there is a risk of eclampsia and a risk of stroke, of a lot of neurological disorders. So optic nerve sheath diameter has been used in the context of pregnancy. But the main thing to know is that there is no study validating specific cutoff of optic nerve sheath diameter in the context of obstetrics. So we use non-validated cutoff validated in the non-obstetric population. We use it in the obstetric setting. And for me, this is stupid, because maybe there is an edema of the optic nerve sheath, and maybe this edema is responsible for an increase of the optic nerve sheath diameter without intracranial hypertension. We don't know. So optic nerve sheath diameter was used in the context of severe preeclampsia, and it was shown that almost 20% of the severe preeclamptic parturients had a cutoff suggesting elevated intracranial pressure, but out of pregnancy. So in the context of pregnancy, we don't know what does it mean. Does it mean that those patients have an elevated intracranial pressure, or does it mean that it is a severe preeclampsia with an interstitial edema and an edema of the optic nerve sheath? A reflect of an indication of elevated intracranial pressure. So I don't like really optic nerve sheath diameter. I prefer transcranial Doppler, and it is not very well studied in the context of pregnancy, but we can use it when we have a patient with severe preeclampsia. We can use it to detect intracranial pressure and to categorize the severity of the severe preeclampsia. In fact, when we have a severe preeclampsia, we can use the whole body ultrasound. We published this case report in a critical parturient. She had a very big HELP syndrome, so severe preeclampsia with a HELP syndrome, hemolysis, elevated liver, low platelets, and also a very, very, very big postpartum MOH. In this case, I think that this patient is still alive because of point of care ultrasound, because she was she had an anemia, a very big anemia, and we didn't know if it was due to the hemolysis or to a postpartum MOH, and there was no external bleeding. So with ultrasound performed by the obstetrician, we were able to see a very big hematoma in the uterus, and we saw that it was a postpartum MOH and not just an hemolysis due to the HELP syndrome. And then we use ultrasound to put central venous access because she had just 5 platelets due to the HELP syndrome. Then we also use ultrasound to see that she had a pulmonary edema and to manage hemodynamic states with the delta VTI after passive leg raising. This patient need 30 culoglobulaire, I don't know, red blood cells. She needs 30 red blood cells, more or less 5 times all her blood volume. So she was in very critical situation, and the use of a point-of-care ultrasound was very, very, very useful and life-saving, I think. So after this case report, we implement this recommendation in the French guidelines for the postpartum hemorrhage, and it is now in the guidelines, in our guidelines, that we can use the fast abdominal ultrasound in case of postpartum hemorrhage. When they in the context of postpartum hemorrhage. The last question is, what is the necessary level for the people working in the context of obstetrics? I think that everybody working in the context of obstetrics should have at least a basic level of point-of-care ultrasound, and maybe at least one people in each team working in obstetrics should be very good in point-of-care ultrasound with what we call the level 2 in this pyramid. So in conclusion, the take-home messages. The use of point-of-care ultrasound in the context of obstetrics is very useful. It is very important. For me, point-of-care ultrasound in the obstetric setting is like a lethal weapon. It is a very useful tool. It is a very useful tool for fluid management. And we saw that severe preeclamptic patients are very prompt to exhibit pulmonary edema, and we must be restrictive with the fluid expansion. And so we need to monitor if the fluid expansion is necessary through delta VTI after passive leg raising, and if the fluid expansion is safe through the lung ultrasound, anterior lung ultrasound, and if there is no B-line, it is safe. Point-of-care ultrasound is also very useful in the context of acute breathlessness during pregnancy, and we have seen some specific algorithm. It is also very useful to differentiate and to diagnose pulmonary edema, which are very, very, very frequent in the context of pregnancy. We can have some indication about the intracranial pressure in case of severe preeclampsia, and we can also manage postpartum hemorrhage through abdominal point-of-care ultrasound. I really thank you for your attention. Muchas gracias. Y puedo responder a las preguntas si hay preguntas.